activities and lifestyle kind of things to manage those. But all those kind of fit together, even though they're different things or process that patients have. They all end up with the same risk factors, the same things you have to modify for the patient. So we got through angina. I can't remember, did we talk about hypertension? That's not bad. No. All right, so we'll continue on this thing and then we'll talk about hypertension after. So that's, I can't remember nothing. So, yesterday we talked about the concept of atherosclerosis, where you had the plaque formation happening in the arteries, which is something that's going on not just in your coronaries, but it's also happening in your other parts of your vascular system. So that's what we have today. We're going to talk about peripheral arterial disease and peripheral venous disease, and kind of how you can tell whether a patient has one or the other. In general, both of the mechanisms are happening in your patient, but the presentation is a little different when you're talking about arterial versus venous. There should be a box in your textbook that has them together so you can actually see the comparison of what you see with a person who has an arterial problem versus a venous problem. And those are things that help you kind of identify what the leg or extremity looks like, because that's what they're mostly talking about. Things that are happening in your lower extremities. Kind of thing we talk about this. Although it's happening in the whole vascular system, that's the kind of thing they're looking at to see what is happening with your patient. Okay. So when you look at peripheral arterial, peripheral or venous disease, they're actually talking about those systems, whether it's arterial side versus venous side, and how you kind of remember them, just in general. If you think about arterial, that's going to be pulses kind of thing going on, so diminished pulses in the patient, pale in color, because that's where the blood is going. If you think about what you're seeing, what that system does, it actually takes blood to things. Because arteries take things away, right? Venous returns things. So you can think about what the extremity is going to look like when a patient has that type of disease. So arterial side, you're going to lose a pulse, pale in color. It's paler when you elevate it. Okay, because that's, you see those things when those patients have those kind of issues. When you're talking about the venous side, you're talking about venous return. So if venous is not returning anywhere, it's staying where it's not supposed to be. So that is edema. When you look at a patient who has peripheral venous disease, they tend to have edema in the extremities. It's congested with blood, so it looks red in color. When they talk about rhubarb, that's what they're talking about. So that's a person on that side that's going to have, the thing about it is, they're not going to have the same coolness that you see in an arterial person. Because on the arterial side, the patient also has cool extremities, that kind of thing. But on the other side, you have this congested area on the venous side where everything is going to be enlarged. You have edema that's associated with that. And then when you talk about patients who have these disorders, what we have to do is manage that whole thing about if it's on the arterial side, I got to look at increasing blood flow. And if I have the venous side, I got to increase venous return. Okay? So let me just write down on the board so we kind of, because I know I keep going back and forth. I'm going to slap my senses. Okay. All right. So this is the arterial side. Okay. So that's blood going away from the body, going out to all the extremities kind of thing. So when you see this person that has this problem, you lose pulses. I have to spell on here. Okay. Pale in color. Okay. Also, when you think about it, blood is not going to someplace, kind of like we talked about the coronary arteries, they're painful. So those are all kind of characteristics that you see for the patient on the arterial side. Okay, so it's going to be pale, they're going to have, pulses are going to diminish, and they can have paralysis, all that kind of stuff. If you think about those things that are happening, arterial occlusions are kind of the thing that kind of guides what you see in this patient. On the venous side, this is where blood returns back to the heart so it can go out to the body. So the venous side is going to be more congested when you talk about this patient having this problem. So this person actually has congested, I'm going to put congested and enlarged, and then edematous. So we got all of the adjectives we can use to talk about what that extremity looks like. Because remember that it's not returning anywhere, so that's why you have that So yes, you have diminished pulses with this one too, but it's a different type. It's not going to be as diminished as you will see on the arterial side. So you can have some decreased pulses here, but it's to a lesser degree than you would see on the arterial side. This one definitely, when you talk about arterial stuff going on. Okay. With this one, you also have the color is more rubor. That's what they call that. It's more or red kind of thing. All right, and that's mainly because you have blood in the leg. It's not moving anywhere. So those are the kind of things you see with this person. But the cornerstone of kind of telling them apart is when you have edema, you think venous. And if you think about all those people who have, we talked about heart failure yesterday, and they have the peripheral edema and stuff that's happening with these patients, the process by which this happens is the same. It's just that it's going, the heart is failing, that's the problem for this particular person. But generally when you see patients who end up having coronary artery disease, that process is going on over your entire body, and it's going on in the arterial side versus venous side. So patients can end up having symptoms of both kind of things. But these are the things that we kind of look for to see whether your patient is having one or the other. Now the thing about it is that we treat them a little different. Okay, that's the reason that you look at the characteristics of what the leg looks like, because that's where it usually happens. Don't get me wrong, it happens other places, but generally we're talking about the legs when you talk about this. But generally when you see these people that are actually having this kind of stuff go on, you see these kind of things happening, but what other things do you think might be happening with the patient? What are they telling you, maybe, when you're doing their assessment? Huh? Their legs are in pain. Because one of the things we look for is what we call intermittent claudication. Now this kind of goes back to that whole seesaw thing that we talked about with oxygen demand and supply, where you're talking about the coronaries. Basically now when you're talking about intermittent claudication, you're talking about the same process happening in the legs. Okay? When a person gets up and does activity that requires more oxygen, if you don't have blood flow, no tissue perfusion means pain in the legs. So what happens is a person has this pain when they walk or do activity. When they sit down, it gets better. Then they get up and walk again, and it hurts at a certain point, they sit down and it gets better. So basically what you're looking at is now you're looking at peripheral oxygen demand and supply is going to be affected. So intermittent claudication is one of those things we look for. When patients tell you, oh yeah, I have that. So we're looking to see what is going on as far as, is this something that's new? Did you have it for a while? Is it something that's getting worse? Because the thing about it is you also look at that pattern of pain that's associated with that. Is it a person that used to be able to walk a block and now they can only walk 30 feet? So that tells you that there's more than likely you worry about ischemic limb at that point, meaning that the person can actually infarct that limb and lose it, get gangrene, all that kind of stuff going on, because there's a change in the pattern. You know, if you know you were actually able to walk a mile and then you have pain, and now you're starting to have pain all the time, or you're having pain at rest, those are things that are worrisome. Breast pain especially is one of those things you worry about this patient actually losing the limb or having an amputation because of that. So no circulation is going on. Because at rest you shouldn't be having pain. That's the issue that they're talking about with this. So intermittent claudication is something that you may see in a patient, and is considered diagnostic, because then we can actually do some other testing to confirm what we think is wrong with the patient. So yeah, we see there's a decrease in perfusion. The patient has pain when they're moving around. The next thing we're going to do is actually start saying, well, what are your risk factors? And guess what? They're the same ones for every other cardiovascular disease. So that's going to be a person who smokes, who is diabetic, hypertensive patient, sedentary lifestyle. You know, all those things come back into place. So you'll see them over and over again as far as risk factors for patients. Okay. Then we'll start doing some diagnostics and say, hey, what's going on with this person? So what's going to be the most valuable for us to see in this patient, especially on the arterial side, is going to be an arteriogram. Now, anything that's going to be looking at, or when you have a patient that you think has something wrong with their vascular system, arteriograms of whatever you're doing, because you can do them of pulmonary, you can do cardiac cath as a type of arteriogram, but those are things that look at the vascular system. Why they're significant is that it's going to let me see where I have blockages in the patient. It will also allow me to actually do treatments on the patient as well. So they can be considered diagnostic and they can also be considered therapeutic. So diagnostic to see what is wrong, where it's wrong in the patient. So I can find those areas of where the patient has a blockage. Treatment in that if there's a blockage there that I can use that balloon angioplasty like I can do in the coronaries, I can also do in the legs. So that would be the treatment that I can do conservative kind of stuff on the patient. So I go in and do an angioplasty, blow up the balloon so it pushes the plaque on the arterial walls, put in a stent. The patient's going to have flow of blood just like they do when you do coronaries. That's conservative treatment. You know, it's considered one of those things that's conservative as far as treating the patient. I can also do bypass surgery. When you see people talking about femoral popliteal bypass, or you'll in report, you usually hear FemPop. What they're going to do is go past the areas of blockage by using vein grafts. They'll go by and they're going to actually create a pathway outside of where the blockage is for the patient. So it's just like bypassing coronary arteries. They do the same thing in your legs. So they're just saying they're going from the femoral artery to the popliteal by using a vein or artery that's grafted into there. So they can use cadaver veins, which is what they usually end up doing to actually do that process. Or they can take one from somewhere else in your body and use it. And because we have so many, we can actually do that. So those are because you can harvest them from other places to use. So that's what you're going to see as the more invasive kind of treatment for a patient. Nowadays, you see more of the patient going to interventional radiology and doing the angioplasty first. Only patients who have severe disease do you see getting surgery anymore, just because it's easier to do. And patients usually tolerate it without a problem, and then you don't have the whole thing about as long a recovery time. Because you already know this person is compromised because they already have this disease. So not that surgery doesn't happen, but it's not going to be the first line thing you do anymore. It's going to be more the the arteriogram or angioplasty you do first. Now, of course, you have people that don't comply. You do the arteriogram and you do the plasty on the leg, and then the person still smokes, doesn't try to control their hypertension, doesn't control their blood pressure. That's the person that's usually in surgery by the next year. Okay, so you do have to change, make those lifestyle modifications which go for every single disease process in cardiac. Pretty much it's the same because the underlying thing, remember the yellow brick road I couldn't draw up there yesterday, is pretty much the underlying thing is atherosclerosis. So you need to control that whole process, helps you get all this kind of stuff under control too. There are some medications that we sometimes give before we do this because nobody wants to just go ahead and do anything. They're going to say, oh, let me try it first and see if I can do it. So one of the things that you can actually see given for intermittent collocation is Persantine. You may also see Trental. Those are antiplatelet drugs that help with circulation. They're really old ones that you can see used for this. Plavix, some doctors will use, but it's not really indicated for that, but it's the off-label use that some doctors will actually use Plavix for that. So what you're trying to do is stop platelet aggregation that's going to hopefully increase perfusion to those areas. And that's especially done when you see intermittent claudication on the patient. That would be the most conservative route you would do. The other thing you do is after you have the person, you say, I come in and I do my plasty, you're going to have an improvement of symptoms to some degree, but you will still have patients who still have claudication because you have to open those vessels and they have to make sure everything works. So what we usually do is have the patient exercise until they have pain, or ambulate or move around until they have pain, stop, and you want them to increase a little more every day. And as those take heat or take hold, the patient gets better, then you're going to see improvement overall. Okay, so, but you never want to see a person, anytime a person has rest pain, that's the thing that needs to be reported to a doctor. So one of those things, if you see a test question that says which one of these things is reportable, when a patient tells you he has peripheral arterial or peripheral venous disease, that they have breast pain, that needs to be evaluated. Because what I worry about is if this person ends up with ischemic limb, meaning that I can have a clot, or one of the patient doesn't have perfusion and the person ends up losing the extremity. And I don't want that to happen. That's what you worry about. So it's pain at rest is one of those things that always has to be evaluated. Now your book is going to go into great detail about telling you whether the blockage is above the femoral ring or below. Okay. It's just one of those things. The major thing is looking at the pathology that it's producing is what you kind of look at. The one, they do actually measure your ankle brachial index, because they actually measure your ankle versus your brachial, your circumference. And then what they do is kind of figure out how much disease a person has, because depending on that, can tell you the extent of disease that people have. So that may be something that that is tested when the patient is getting their diagnostic stuff done. But most doctors look at you and tell which one of these you have just by looking at the color of your extremity, if you have edema or not, if you have a pulse or not, if you have pain or not, and those are things that they kind of evaluate as you go along. The major thing, of course, is knowing that you have to change risk pathology. You have to modify your lifestyle kind of thing, and then we can do interventions to actually address that. You're looking for, yes, I can go have this person who ends up doing this plasty, but if you're still smoking, it's just like not doing anything. So those are things that patients need to understand about that. But you will have some that still smoke and don't take medicine, and they'll tell you that biggest day in the hospital. Yeah, I'm not taking this medicine because I'm still on smoking and I'm still on do stuff. But that's, you can't really help that problem that sometimes happens. But what can end up happening, the worst case scenario when you have is ischemic limb, and what you end up seeing is a person that loses pulse. If you lose the pulse totally, then you have severe pain. You have those 6 P's that go along with occlusion. For that one, you're going to see a patient who has, it's actually 6 P's, but it's 5 P's in a C. The 6 P is a fancy name for cold. So you think about if you were sitting on your leg, because that's how you get the idea about what happens when you're talking about an ischemic limb or somebody that's you're worried about losing their limb because of arterial occlusion. Think about sitting on your leg. Maybe you were watching the game on Sunday and you sat on your leg while you're watching the game. You can't believe the whole thing is happening. And so finally you just get up in disgust. You've been sitting there for 40 minutes with your leg under your butt. Okay? So when you take your foot out and put it on the floor, what happens? It tingles. So tingling is paresthesia. Okay. You also told me pain. All right. Is it easy to move?
No.
Not usually. So you feel like you're paralyzed. It'll be pale in color. Hopefully you do have a pulse, but this is what you're worried about is gone. And the 6th one, like I said, is fancy for cold. So they couldn't put 5 P's in a C. So they did all P's. So poikilothermia is the fancy name for a cold. All right? So this is what you worry about when a patient has an ischemic limb. Because this is telling you I have arterial occlusion. I need to fix this right away, or the patient can lose the extremity. Because if all of these things are happening, because this is the big one. I know if this person has pulselessness, I don't have perfusion to that area. If that's going on with this patient, that's why they're pale. That's why it's painful when they try to move it, or they may not be able to move it at all. Those are the things you worry about when you're talking about this. This is one of those things, when it happens to a patient, you got to intervene now. Okay? If I don't intervene now, this person can lose this limb. So what'll end up happening is this is a person that goes automatically to interventional radiology if they're in the hospital. That's just what happens. We're gonna go in there, at this point, we're gonna look for the clot. So that's the embolectomy. I can also, because if I fish it out, that's embolectomy. But if I go in and instill medication at the site, I can use a thrombolytic drug to dissolve the clot and hopefully reestablish perfusion in the extremity. And then they'll usually do a plastic while they're in there to make sure that vessel is open and put a stent there. But that's what I worry about. Now, if this person has been ischemic over time, remember, anything that's farthest away, you start to see necrosis in toes. You know, it always starts at the farthest part away. So that's why the end of your toes get necrotic first, and then it starts to rot up on top of that. The bad part about that is you can have some people, especially you think about this process going on with somebody who doesn't have diabetes, but add diabetes on top of it, they can't even feel that. You know, they're walking around, they might have some pain, but they don't even realize it. They just put their shoe on and keep going. And then you see them later in the day and half their toe is black. Okay, that's the thing you don't want to happen to patients. Because necrosis starts to happen. It always happens farthest away first. So the toes are the things that are going to be the things you can't salvage early on. So some people may end up actually taking off part of their toes or taking off a few of them. And that becomes a whole nother thing. You don't realize how much toes are important until you don't have one. It changes your whole balance. Patients have to have therapy just because they have one toe taken off. And people don't understand, they think, this is one toe, but it has a big part of your balance by doing that. So that means the patient ends up in rehab because of that. The other thing is if they end up with the amputation, that means they can, you know, that's the surgery. Then they're also going to have rehab if they're fitted for a prosthesis. They estimate that the year after a patient has an amputation, it costs about $130,000 between prosthetics, rehab, and all that kind of stuff going on. So that's not, you don't want anybody, the whole thing about having a leg cut off, nobody wants to have that anyway. But the bigger issue is that, you know, now this person you have to change your house around, do things, it's all kinds of things associated with that, which you don't want to happen. You want patients to get better, not for this to be a continuing issue that happens with your patient. So early recognition is key, and then you have to do those lifestyle changes that are associated with that. The other thing that happens in our venous system that you guys have is a deep vein thrombosis, or DVT. Now this is just telling you where it's coming from, so you know it comes from the venous system. And the patient ends up having impairment or a thrombus that comes from the deep veins of the legs. So you're talking about the large vessels in the leg that end up being the source of where this comes from. Now, what are the risk factors for patients actually developing DVT?
Immobility.